So thank you, everyone. We're so delighted to have you here at the ATI seminar series, and very delighted to welcome Dr. Emily Christie as our speaker for today. Just a few things to go through before that. And first and foremost, would like to just acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich this vibrant community. We'd also like to thank Paladin for their support of the ATI seminar series. So welcome to everybody. My name is Sophia Ahmed. I'm a general nephrologist and the University of Alberta Sex and Gender Chair. It's my pleasure to be the moderator for today's ATI seminar series. So just a reminder, just for everyone who's here, that the ATI Research Day will be next Wednesday at the Lister Conference Center. And you can still register to attend this both either in person or via Zoom. And Sean is going to put the registration link in the event webpage, as well as the program booklet in the chat, so you can see that there. Just before we start, a few housekeeping things. So I'd like to ask people to mute themselves. And there's no pressure to keep your camera on. We're all on Zoom a lot, so please don't feel the need to keep it on. But if you'd like to, go ahead. If you have questions throughout the presentation and certainly afterwards, and we hope that you do, please feel free to put them in the chat or raise your hand. I do want to highlight that if there are questions that you would like asked, but you don't feel comfortable asking them, please feel free to private message me and I will ask them on your behalf anonymously. This presentation will be recorded, but the question and answer period will not be posted on YouTube afterwards. So we really want to encourage great discussion. So without further ado, I will move on to introducing our speaker for today. And we're really fortunate to have Dr. Emily Christie, who is a practicing nephrologist at the University of Alberta Hospital here in Edmonton. Dr. Christie completed her medical training at Queen's University before coming out west for her internal medicine and nephrology fellowship before deciding to stay for a transplant nephrology fellowship. And she now is the program director of the fellowship program. So we've really been fortunate in that way. Dr. Christie has also completed a Master's of Healthcare Quality Improvement from Queen's University and currently serves as the Education Committee Chair for the Alberta Transplant Institute. Her research interests, in addition to, of course, today's topic, include equity and provision of care and access to organ transplantation. So without further ado, we're very fortunate to have Dr. Christie, and I'll pass the mic to you. So thank you.
Thank you very much for that very kind introduction, Sophia. So my talk today is about policy and statistical barriers to organ transplant for transgender, non-binary, and gender diverse patients. So I'm pleased to talk about this topic today. I have no conflicts of interest to declare, and I will not be discussing any off-label use of drugs or devices today. The objective of my talk today are to give a reminder for those who know and new information to those who don't about definitions for transgender, non-binary, and gender diverse. I want to review policy and structural barriers to care and organ transplant, and also highlight some specific pre-transplant, post-transplant, and donor considerations in this realm. The one thing I do want to tell everyone, which Sophia already kindly said, is that I am a nephrologist, and I know that these ATI rounds are for all people that are associated with organ transplantation and donation, and I will inevitably be focused a bit on renal transplantation, but many of these issues apply broadly to all of transplantation, and a lot of the things I'm going to talk about will apply to all of clinical care for transgender patients. So the first thing I want to review is just the definitions for sex and gender. These are two important and non-continuous items. So sex really is biological characteristics. So this comes down to chromosomal, anatomical, and physiologic factors. And there are distinct categories of female, male, and intersex. Gender, however, in contrast, is really a culturally defined category, and it's different based on different cultural areas, and also different based on how one views themselves and their own identity. This can be culturally defined roles, attributes, social characteristics, and expressions in every way possible, and there are an endless number of gender identities that exist. And sex and gender are not continuous with sexuality specifically. For the purposes of this talk, it's important to sort of go through definitions about transgender. So this is a person whose gender identity does not correspond with what is socially expected based on their sex assigned at birth. And this is often used as an umbrella term to refer to any range of gender identity and experience. Non-binary is a slightly different term for a person whose gender identity doesn't fit into a male or female binary. So they may identify as both male and female, as neither, or as something entirely different. And these definitions come from Egal Canada, which is a human rights trust and very helpful website to visit. The last one is gender diverse, and this definition comes from the American Academy of Pediatrics, but it's an ever-evolving array of labels that people may apply when their gender identity, expression, or perception does not conform to the norms and stereotypes others expect. So for the purposes of this talk, I'll be referring to this sort of diverse group as TGD, so those who are gender diverse, because this includes transgender and non-binary people. I also want to just review, because I'll be talking about gender affirming care. This is an umbrella term again, and not all TGD patients may choose to pursue hormonal or surgical therapies as part of their care. But there are two main categories. The first is gender affirming hormone therapy, or GAT. The primary goal of this is to induce physical changes to match that patient's gender identity, and basically to try and maintain physiologic hormone levels for the person's target gender. As far as just a brief overview of the types of medications that we tend to see used most frequently. So for feminizing hormone therapies, it's often going to be estrogens and anti-androgens, including things like spironolactone and cyproterone. There's the use of GnRH agonists as well. And then on the masculinizing side, you can have mostly testosterone based, but there's a really large variety of formulations that are in use. The second sort of main arm of gender affirming care is gender affirming surgery, or GAS. This really can apply to any surgery that a TGD individual may use to align their body with their gender identity. So this can include facial surgeries, vocal cord surgeries, thyroid cartilage surgeries, body contouring, breast and chest surgeries, which is often used the term top surgery, and then genital or gonadectomy surgeries, which is often referred to as bottom surgeries. Unfortunately, TGD patients do suffer from stigma, discrimination, and mistreatment, and this negatively impacts their social determinants of health, leading to significant health inequities. There's a disproportionate burden on these patients to educate their providers and advocate for personalized care. And there are multiple barriers to accessing healthcare, resulting in unmet healthcare needs for the population. And there really is a clear need for inclusive primary and subspecialty care. The risk with these patients is that they have delayed or reduced access, and this can result in compromised or incomplete care. And then getting into some of these sort of organizational policies and structural barriers that exist for these patients. So non-inclusive organizational policies are something that most patients are not going to have to think about. But for our TGD patients, one of the biggest things is patient information collection. So many EMRs, or electronic medical records, do not have the capacity to collect or represent this information appropriately. And this is referring to things like the person's preferred or used name, their preferred or used pronouns, their sex assigned at birth, and their gender identity with inclusive and non-dichotomous terms. Reducing the frequency of misgendering, for example, so using the incorrect pronouns for a patient, is known to have quite significant positive impacts on the health and well-being of these patients. So it makes a big difference the number of times that they have to deal with this in their regular day life and in access of healthcare. Consistent documentation will also correct the underrepresentation of TGD populations in research, quality improvement, and health service delivery planning, and would hopefully help promote development of more TGD-specific evidence-based care, because right now I think patients are not identified, and so we don't actually know what their needs are. It's important that we educate all healthcare providers on provision of inclusive care with cultural humility, being key to reducing these structural barriers. And if you think about patient information collection, this is often their first contact with the healthcare system and not necessarily going to be with a nurse or a physician. So it's important that all members of the healthcare team are involved in making these positive changes. As far as hospital policies go, regarding gender, this is a major source of stress in TGD patients, and this has been identified time and time again in self-reported data as far as stressful experiences within the healthcare system. So this refers to gender cohorting that occurs in hospitals, not only in the inpatient world, but also for outpatient testings. In some centers, and then also gendered public washrooms, which still exist at our own site that we're at right now. As far as the next structural barrier, this comes down to financial barriers, and this is quite a complex and large subject to talk about. But overall, healthcare and insurance policy coverage is quite variable when it comes to TGD-specific care. TransPulse Canada is a community-based survey of health and well-being of trans, non-binary, and two-spirit people in Canada. And in their 2021 report talking about sort of access to care, they, based on their survey data, saw that 1 in 3 Canadians who identify as TGD are on a wait list for gender-affirming care, with treatment and travel costs being the most common barrier that people face. In Alberta, for example, top surgery is generally covered and available at multiple centers. However, bottom surgery is not offered in Alberta. And in Canada, overall access to bottom surgery is really quite limited to a single center in Montreal, the GRS clinic, which is accepting national referrals. They are a private clinic, which is separate from the hospitals in Montreal. And this actually means that their capacity to accept more complex patients and specifically dialysis-dependent patients is entirely limited. So it means that the access for our patients is reduced. There are surgeons that are qualified in other provinces who are trying to build up practices such that they would be able to accept national referrals. So there is some hope, but currently the waitlist for the Montreal GRS clinic is over 2 years. So it means significant delays for these patients. Additionally, other GAS surgeries are sometimes defined as either plastic or cosmetic, which means that they do not get covered in most provinces. So as an example, facial contouring GAS is only covered in 2 provinces in Canada currently. One of the sort of ways around this most recently has been patients traveling to the US when they want to access surgeries that are not available in Canada. The US has multiple specialist centers that are offering gender-affirming surgeries. There is a high cost associated with this, and in most provinces, this is not going to be covered. And unfortunately, that would mean a personal cost to the patient for travel as well as healthcare cost. The US prices that I have, to sort of give you a ballpark, are a couple of years old, so they're probably higher now. But for male to female surgeries, generally it was ranging somewhere from 12,000 to 25,000 US dollars. And for female to male surgeries, somewhere between 25 and 35,000 US dollars. So quite substantial amounts of money. And as far as sort of Americans' access, just as a comparison for them, there were 67% of US states Medicaid cover gender-affirming hormone therapies, and less than 50, so just around 49% cover gender-affirming surgeries. As many people are aware, there have been significant changes in the political environment to the south. So there have been restrictions, bans, and legal challenges that have been ongoing. And it may mean that our TGD Canadians may need to travel further internationally to access care. And this would mean incurring likely higher travel costs and potentially higher costs for accessing care. Again, while I can't meaningfully cover the entire sort of systemic discrimination ripple effect, it is important to mention that TGD patients, despite no real differences in education levels, are disadvantaged in many ways by discrimination. And this affects employment, this affects housing, and as I mentioned, if there are large price tags on the therapies that are medically necessary for their care, that means that access to those is going to be even further reduced. I'm not going to talk too much about detail in this, just in the interest of time. There was a Canadian study in 2020 by Abramovich that was taking a look at sort of the disparities among the TGD population. And there's many studies, but I wanted to present this Canadian one. They used Ontario-based ICES data, so Institute for Clinical Evaluative Sciences. They reviewed sociodemographic characteristics, health conditions, and health service utilization patterns among TGD individuals compared to the cisgender population. So they had about just over 2,000 transgender individuals that were included within this study, and then a 5% random sample that was about 10,000 patients of age-matched cisgender individuals within Ontario. Unfortunately, this showed that across the board, transgender patients had lower incomes, they had higher rates of asthma, diabetes, COPD, HIV, and mental health diagnoses, and also had higher health service use. So this was primarily relating to urgent care and emergency care use. Other studies have shown that there is also a higher prevalence of acute kidney injury and CKD, or chronic kidney disease, among transgender and TGD populations. And this may actually reflect the higher incidence of diabetes, which is one of the main causes for chronic kidney disease within Canada. One thing to consider too is I had mentioned about reduced primary prevention and healthcare access and how that can potentially compound here into these disparities that we see across different disease processes. Measurement of kidney function itself remains unclear within the TGD population. The common EGFR equations, which we use every day, were designed based on what we think are binary sex inputs, and the data was collected without very granular information on sex and gender. So it's hard to say sort of what these exactly were based on, but all these calculations have been, designed around male or female inputs. And there has not been any evaluation specifically in the TGD population. And many patients may actually fall in between either of those. And so it can be quite a substantial difference when you use male versus female in calculation of measured kidney function with EGFR. Furthermore, we don't actually know what the impact is of gender-affirming hormone therapy, as this remains undefined, and there's evidence that's growing, and Dr. Collister can probably talk more about those things, but it's an evidence that particularly masculinizing therapies may alter EGFR calculations, and there's uncertainty in calculation of these basic kidney functions, which will impact CKD management and access to transplantation specifically. We know from international data that there is gender-based disparities in referral for and receipt of preemptive kidney transplants specifically, and most often cisgender women are facing the greatest barriers, but no studies have explored this further in the TGD population. And with the inaccuracy and imprecision of the kidney function measures, we may actually be systemically disadvantaging a subset of kidney failure patients and delaying their access to transplantation. So this is sort of a summary of what I'd like to cover and just talk about as far as sort of the different phases of care for patients and the different barriers that we see within there. So at most centers, pre-transplant assessment is going to include risk association with venous thromboembolism, cardiovascular risk, malignancy screening, mental health screening prior to listing. Post-transplant care, there are some associations with drug interactions, timing of gender-affirming surgeries in relation to transplantation, and side effects of drugs, including and post-transplant polyuria and how those can interact. Post-transplant, a lot of the same things, so ongoing malignancy screening, health promotion. And then on the donor side as well, donor-specific care, including the IIRD criteria, tissue donation, and disclosure and inadvertent outing that can occur. So I'm going to start with talking about pre-transplant candidates. Venous thromboembolism is one of the big risk factors that we talk about with any surgical preparation, but historically, we have used data on hormonal therapy for other indications and extrapolated that to those patients who are on hormone regimens for GAT. These studies were often older ones with hormone regimens that are no longer in use today and didn't really reflect the risk for modern GAT therapy. There is growing literature on the impact of GAT on medical and surgical preoperative risk, but there are still substantial knowledge gaps that exist. Limited studies have evaluated surgical complication rates on patients who are either on or off of gender-affirming hormone therapies. The easiest one to access has really been mastectomy because masculinizing chest surgery or mastectomy is an easy target to identify as far as billing codes. And it really, in those studies, showed that there was no difference as far as surgical complication rates, whether people continued on their hormone therapy or if they discontinued it for any period of time perioperatively. The most recent recommendations from the Society of Perioperative Assessment and Quality Improvement state that we really don't need to discontinue or interrupt therapy. They recommend continuation of all androgenic hormones, estrogens, and progestins throughout surgical risk. Cardiovascular risk with GAT remains quite undefined as evidence is quite heterogeneous and conflicting. There may be some increased risk for myocardial infarction among TGD patients on feminizing hormones. And we know that there are unfavorable lipid profile changes associated with TGD patients on masculinizing hormones or testosterone, but the impact on longer-term cardiovascular risk has not been well defined. Recognition of these other co-occurring risk factors, including things like smoking, socioeconomic status, reduced access to care, and physiological stress that disproportionately affect the TGD population is also important as far as assessing their CV risk, although these things are a lot harder to assess. Sex steroid receptors are expressed throughout the vasculature, and there's sort of growing interest in how these are functioning and how they modulate risk. Masculinizing hormone therapy, so on the right side of your slide, may trigger endothelial dysfunction by disrupting nitric oxide pathways, increasing vascular inflammation and renin-angiotensin activation. On the other side, feminizing hormone therapy will increase oxidative stress and inflammation within the vasculature. These are interesting to talk about. However, there has not really been any translation to clinical outcome differences, but there's further ongoing research into how these affect physiology. As far as other ways of assessing perioperative risk, so metabolic risk and BMI is a big part. So body mass index or BMI significantly increases in most TGD patients on feminizing hormones, but not so much those who are taking masculinizing regimens. This can impact their candidacy for transplant because we do have BMI cutoffs to be approved, and these are variable between centers, but generally range anywhere from 35 to 45 kilograms per meter squared. So TGD patients who may already be overweight could potentially become ineligible for transplantation if their weight rises substantially after they're started on hormone therapy. Furthermore, transgender women, independent of their GAT status, do carry a mildly increased risk of developing insulin resistance and diabetes. There have not been any studies evaluating the incidence of new onset diabetes after transplant in the TGD population, but they may carry an increased risk. The potential benefit of novel weight loss therapies, including the GLP-1 agonist, has also not yet been evaluated specifically in TGD populations, but overall should have similar effects and benefits. Malignancy screening, all transplant programs complete age-related and organ-specific cancer screening prior to approval for transplantation. We know that immunosuppression may increase the progression of solid organ malignancies, and despite unchanged incidence of common solid organ cancers compared to the general population, just progression may be faster. There's no clear evidence for increased risk of malignancy among gender-diverse patients, but little research and representation. For gender-affirming surgery, there is persistent cancer risk if you have persistent presence of tissue. So particularly if you have cervix, uterus, breast tissue, or prostate that remain in situ. The surgery itself is not going to alter that risk unless the tissue is being completely removed. So anatomic or organ inventories are a recommended method to encourage appropriate screening for all of our patients. The impact of GAT on overall cancer development also remains uncertain. There's growing evidence of oncogenic signaling that sex hormones play in many types of cancers. Some evidence suggests that breast cancer risk increases with the use of even short periods of feminizing GAT, and this may also increase with masculinizing GAT. There's very low cervical cancer screening uptake among TGD patients, which is understandable, but this is significantly actually improved with GAT access and a multidisciplinary approach to allow easier access into cervical cancer screening programs for TGD patients. Similarly, prostate cancer screening access remains low. There's also no clear guidance on how to do PSA screening in TGD populations, and there's no consensus on what a normal PSA value is for somebody who is taking gender-affirming hormone therapy. Mental health is another part of our normal assessment of anyone coming forward for transplantation, as we know that this is a very stressful environment to go through. We also know that chronic illness, including chronic kidney disease, is strongly associated with higher rates of depression. We know that the TGD population, unfortunately, does have a higher risk of mental health diagnoses and a 10 times increased risk of attempting suicide. The potential benefits of gender-affirming hormone therapy are quite clear in studies that they reduce gender dysphoria, they improve global function, quality of life, and psychological well-being, and really deal with lower rates of depression and suicidality. So it would be important to make sure that patients have access to this as a way to improve mental health coming into kidney transplantation. Furthermore, depression has been independently linked to poorer outcomes in the post-kidney transplant population, and this includes mortality and death-censored graft loss. So the graph on the top right here shows survival curves. Even at 12 months, you can see that there's a substantial separation between these lines. So these are the patients with depression, and these are the patients without depression. The lower graph here is a cumulative graft survival, so you can see that the separation occurs closer to the 3-year mark. Now, this data is from 2010, so hopefully with increased recognition and support for mental health, these curves have improved over time for all patients who are coming forward for transplantation. We know that there's appropriate treatment and social supports for SOT recipients with mental health diagnosis will offset this disparity. And for the TGD population, GAT is really an incredibly valuable tool for optimizing mental health and preparation for SOT. Historically, there were guidelines that recommended withholding gender-affirming hormone therapy when patients were undergoing transplant or any major medical intervention. And as I've shown you, these are no longer really being supported by data. The psychological effects of withholding GAT, even for a short period of time, can be quite substantial for TGD patients. And depending on the timeline of the regimen that's being held, there can be unwanted detransition-related physical changes that are associated. And really, the most important is to have shared decision-making regarding individualized risk management, as many patients may choose to continue on hormone therapy, even if there is an unknown or unclear risk associated with that. The uncertainties in preoperative risk assessment are a major barrier for transplantation for TGD patients. And due to all of these potential concerns and a lack of expertise and a lack of sort of data around these populations, more specialist consultations are often imposed on TGD transplant patients, which lengthens workup and introduces further barriers and delays to listing. So this is something that's important to clarify so that these patients can move quickly through their assessment. Now I'd like to move on to talking about post-transplant care considerations. So drug interactions and immunosuppression is a major question that comes up, and there are no major drug interactions with the common immunosuppression regimens that we use. One thing specific more so to kidney transplant is polyuria, which we commonly encounter in the early post-kidney transplant period due to osmotic diuresis and tubular injury during procurement and transplantation. Patients who are on feminizing GAT regimens, I had mentioned earlier, can sometimes have diuretic side effects like spironolactone is commonly used. So these patients might be at increased risk for worsening polyuria in that perioperative period, and a higher risk for subsequent acute kidney injury if their volume status is not closely monitored post-transplant. So the question about whether or not you should hold some part of their GAT therapy remains within the literature. Also, sensitivity to side effects post-operatively, particularly those that cause physical changes in TGD patients, is important as body image and gender dysphoria are very closely connected. So weight gain, fat redistribution, and other body changes from glucocorticoids that can change face and body shape temporarily. It's important to warn patients about that and make sure that they know these are temporary changes. Hair loss related to tacrolimus or hirsutism related to cyclosporin or other potential side effects that can have varying impacts on self-image of any patient. Addressing these concerns is really key and sort of making sure patients are prepared such that they have continued compliance with their immunosuppression post-transplant. As far as osteoporosis and fracture risk, we know that the long-term use of glucocorticoids, which is common in the post-kidney transplant patient, predisposes to osteoporosis and fractures. Longitudinal follow-up studies that are ranging anywhere from 10 to 15 years suggest that there's no negative impact of gender-affirming hormone therapy on bone density. We do know, though, that there is the use of gonadotropin-releasing hormone analogs or GnRH analogs in TGD youth is associated with bone loss. However, this is temporized by GAT. And same thing goes for gonadectomy, that there is an increased risk factor for bone loss, but again, can be temporized by gender-affirming hormone therapy. Gender-affirming surgery and sort of the timing of it, whether that happens in the pre-transplant or post-transplant is another common question. We know that immunosuppression is going to cause delayed wound healing and infection risk being higher post-transplant. And so many procedures have a high risk for infectious complications, especially bottom surgeries. And so presumably those will be higher in the immunocompromised patient post-transplant. So ideally, if we could complete pre-transplant prior to the initiation of immunosuppression, that might be better as far as risk management. Things like skin flaps or buccal mucosal grafts are not uncommon, they are not uncommon. They're very common as part of bottom surgeries. And this does have a higher risk of infection. Additionally, any implant use for sexual function or body modification will have an increased risk. So as an example, penile prosthesis will have an infection rate reported anywhere from 4 to 40%. So sometimes can be quite high. And this may be a consideration for patients who are pre-transplant that they may wish to choose a different type of surgery or choose to not go with an implant if they know that they're then going to be immunosuppressed post. Other things like continuous dilatation or vaginal stretching procedures are often required to prevent canal or introital stenosis for those who are having neovaginal procedures. The risk for infection is most commonly UTI with this, but there's also a risk for urethral or bladder damage, which could be quite substantial if you're thinking of a kidney transplant patient. The use of the thigh or groin flaps for gender-affirming surgery can also potentially involve the iliac or femoral vessels, depending on the type of technique, surgical technique that's being employed. So iliac vessels for nephrologists is a common site for anastomosis and kidney transplantation. So anything that would be close to that would potentially make that site not usable for transplant. And the femoral vessels are not uncommonly accessed for dialysis catheters. So this again may impact patients with CKD or end-stage renal disease. Any surgery that's going to require manipulation or extension of the urethra is going to have a risk of stricture or urinary leak. And urine flow is really essential to maintaining patency of these surgeries after they're done. So for our oliguric or anuric CKD patients, TGD patients, they're likely not going to have to undergo a successful kidney transplantation prior to being eligible for bottom surgery just because they don't have sufficient urine output to maintain patency post. And again, this comes down to important psychological impacts of delaying surgery for these patients as they may have to wait for kidney transplantation prior to being able to proceed with their gender-affirming surgery. Reproductive health is another one I just wanted to touch on, but I don't think I can cover in full detail today. But we do know that kidney failure often results in amenorrhea and reduced fertility, and the hypothalamic pituitary gonadal dysfunction is corrected by transplant. So our female patients can have resumption of menses, and preparing the patient for this is really important. Additionally, we want to make sure that we have provision of appropriate contraception and pregnancy planning advice for all of our patients. And we want to meet sexual health needs of our patients post-transplant, which in the TGD population may include additional items such as vaccinations, STI screening, HIV prevention, and access to PrEP. So next I'm going to talk about the donor perspective. So similar to the discussion for recipients, the calculations of eGFR for TGD patients are potentially inaccurate as they're based on that binary sex assigned at birth, and they may vary with gender-affirming hormone therapies. And this may actually impact eligibility for donation. If there's uncertainty, measured GFR should be pursued to clarify whether or not kidney function is suitable for donation. But even that remains a question as far as access and accuracy of measurements. In deceased donation, defining increased infection risk or IRD status, which is donors with increased risk for infection. Current organ and donation procurement agencies generally estimate risk for infectious transmission via organ and tissue donation based on asking a potential donors' family and friends' responses on their sexual orientation, their sexual behaviors, and also things like binary male and female inputs, which not all family members or friends may be aware of for TGD population. Under these regulations, any men who have had sex with men are considered to have an increased risk of acute window period infections with HIV, HCV, and HBV, so hepatitis B, hepatitis C, and HIV. No consensus exists on whether sex assigned at birth or gender identity should be used as far as these go, and this allows heterogeneous application of donor risk assessment criteria with inconsistent access to organ and tissue donation. So policy revision has been being discussed at length for a long time and is certainly overdue. Canadian blood donation restrictions had similar MSM or males who have sex with males recently revised, and Dr. Lee's in Winnipeg was one of the major pushes for this to be changed. And the move is more towards behavior-based change or risk assessments that are gender neutral as criteria to enhance equity and safety in organ and tissue transplantation. In our current practice, the predictive value of pre-transplant risk screening in deceased donor is actually pretty questionable. And I just put up some numbers here of a recent Australian study that was from 2022, where they revealed that the majority of HIV and hepatitis B infections were actually in potential donors that had no identified risk factors based on the questionnaires of family and friends. So there's been growing support for universal NAT testing to replace risk screening. And I'm very pleased to report that less than a month ago, Health Canada announced that they'll be moving to universal nucleic acid testing for all donors. So this is really a step forward in the right direction. The IRD sort of label is separate from universal NAT testing. So labeling organs as IRD or increased infection risk reduces organ utilization, unfortunately, and really results in discarding of important organ transplant opportunities. US data suggests that IRD status is applied to about 20% of their organ donors. We don't have any Canadian data that I could find about this, but our local Alberta data suggests that our rates are closer to about 40% of our donors being labeled as IRD. And data shows that generally IRD are very good quality donors, so they tend to be younger with fewer comorbidities and lower kidney donor profile index scores, which is how we sort of assess part of our sort of quality of organs for transplant. So the use of these organs is very clearly associated with survival benefit long-term compared to discarding them or not using them for transplantation. And in the US, 17% discard rate, despite this data that demonstrates no substantial differences in outcomes at 2 years. And that's about 50% higher discard rate compared to those organ offers which are not considered as IRD. At present, tissue donation in both US and Canada do not have any mechanism to accept IRD or exceptional distribution offers, so if there's any risk that's been identified. So this means that all usable tissues from this sizable donor subset are being discarded in both countries. In the case of TGD patients who may be sort of improperly labeled as IRD, this results in a reduced utilization of a precious opportunity for organ and tissue donation. There's been ongoing discussion about revision of these as well. And Annex E is part of the Canadian standards, which defines the criteria for IRD designation. Public review has just been launched, actually, for the proposed amendments to these changes, and it includes, again, a move to gender-neutral questions and behavior-based risk assessment, which is far more evidence-based. This also decreases the exclusion times following certain behaviors, most of those moving from a 12-month exclusion to 3-month exclusion. And these are really welcome changes to our system, although I do still think there's room for improvement in these guidelines. So we'll see where they end up at the end of the public review. Discarding organ and tissues that are suitable for transplant is really not acceptable in our current environment where wait lists are lengthy and patients are dying every day awaiting transplantation. The donor pool is being expanded to include donation after circulatory death, or DCD, and increasingly comorbid donors, which are often labeled as extended criteria or ECD donors. And these may actually comparatively carry higher risks than those who are being labeled as IRD. But from a resource utilization standpoint, there are also costs associated with decline of these donors, as their workup, the consent process, and potentially even procurement may have already occurred prior to decline happening. Furthermore, there's a psychological impact on a family when donation doesn't proceed, and that can be really harmful. And finally, excluding donors based on sexual orientation and gender identity really discourages donation. It promotes stigma and leads to societal harm by limiting the donor pool for anybody who needs organ and tissue transplantation. The application of the same infection risk assessments for living donors has been called into question as well. So on the side of living donation, it's really quite feasible to do universal testing because we can consent these patients and ask them lots of questions. The TGD patient has a higher probability of flagging as IRD, and currently this requires disclosure to the intended recipient. So the donor candidate this can lead to unintentional outing. So sharing of sexual orientation or gender identity, for example, can be damaging if the donor candidate has not disclosed this to their directed recipient. And so guidelines recommend very clear and early informed consent for living donors who may require disclosure, so particularly TGD patients. Donor candidates may actually choose to abandon plans for donation altogether because of this. They may choose to delay donation after the timeframes for specific risks have elapsed, so that 3 to 12-month mark, or they may opt to actually just participate in paired exchange instead of a direct donation, which is not necessarily a benefit to the patients and to the system. So as far as future directions, I'll just mention a few things that are coming and are happening at our center. So I've been working on, and this ties in nicely to the new changes that are coming, but on sort of the living donor intake questionnaire. So asking the questions to our patients and just making sure we redesign those questions such that they are inclusive as far as patient information collection and anatomic languages is being used rather, especially around malignancy screening. And I'm keen to sort of leverage my association with Dr. Lees and Dr. Collister as far as the patient engagement in this and making sure that we have stakeholder involvement such that we create a really acceptable way of asking these questions. I do want to mention Dr. Collister, who's got support from Dr. Ahmed and myself in conducting this prospective observational study called GAT Kidney. The question is really whether or not GAT is going to impact renal function measures. So in transgender adult men, women, and non-binary persons with and without CKD, how does initiating GAT impact kidney function biomarkers and measured GFR? And what's the performance of our eGFR calculations prior to and after initiation on GAT? So to be able to quantify that difference. So this is very important, and there's more than 6 centers across Canada that are already enrolling patients. And I've mentioned Dr. Murdoch Lees a few times. He's an emergency critical care and organ donation specialist in Manitoba, and he leads this multifaceted national research program and multidisciplinary team, which I'm very grateful to be involved in. But with support from the Kidney Foundation and CDTRP, there's development of online courses for healthcare providers to really develop inclusive care environments for organ and tissue donation and transplantation. Furthermore, there's also been recent surveys of OTDT healthcare workers to identify sort of the knowledge and where that's needed and where supports are needed. And we do have, as I mentioned, this patient and family panel. So this includes transplant recipients, donors that are 2S LGBTQI, and give a really helpful perspective as far as engaging. I do think there are many opportunities exist to advocate for equity and access to transplantation and donation for our TGD patients. And healthcare providers really have a substantial role to play, as awareness and cultural humility are very important to addressing these enduring health disparities for the TGD population in donation and transplantation. All healthcare professionals are going to interact with gender diverse patients, whether or not we recognize or identify that at the time. And expertise in this specialized area is certainly not expected, but I think the hope is that all transplant and donation programs can provide a safe and inclusive environment for care to help reduce sort of the access issues that we've identified. So I hope that I've fulfilled these objectives in sort of sharing this information. And I do just want to acknowledge that it's been really important to engage as well with patient partners. So Cameron Whitley has been sort of the main person that I've worked with, and he's been very helpful as far as further research in this area. So I'll wrap it up there, and thank you very much for your attention. I'm happy to have some discussion and questions.
That's great. Thank you very much. That was absolutely phenomenal, Dr. Christie. Really appreciate it. Just a reminder, there is no seminar next week because of the research day, but there is the following week with Dr. Townsend, and we hope that you will sign up. The Zoom link, a registration link, is helpfully included in the chat. So thanks very much, and we'll see everyone next week, 2 weeks from now. Thank you. Bye-bye.
Thanks, everyone. Bye now.